Hello, my name is Ahmed Assaf from Cairo, Egypt. I'm a professor of ophthalmology in Ain Shams University. I would like to thank Dr. Mahsen Bakali for his kind invitation to participate in this very prestigious and rich webinar. I'm going to drive you for the next 15 minutes through the three cases of different scenarios of hard situation in cataract surgery. So let's start with case number one. It's a routine cataract surgery with clear cornea and irrelevant anterior and posterior segments examinations. So we start the phacoemulsification in the usual way, and while injection of OVDs inside the anterior chamber, you can see this black crescent surrounds part of the lens equator. This denotes areas of weak or absent zonule. Another sign is the corrugations of the anterior capsule, and these corrugations are due to weak or absent of the tension of the zonules on the anterior lens capsule. So this case of mild lens subluxation that could not be detected during preoperative examination and can only be appreciated during rhexis formation intraoperatively. So be careful in this case. Sometimes during rhexis formation, the tear or the direction of the tear of the lens capsule may be abnormal because of the unequal tension on the anterior lens capsule by the areas of weak or absent zonule. So we have to rebuild the tension on the lens capsule every now and then by injection of dispersive OVDs while performing the rhexis. And this is followed by hydrodissection and implantation of capsular support system. Those capsular support systems are similar to iris hooks, but they are more gentle on the lens capsule, especially in the fornix area by the large broad ends. So I prefer this system over the iris hooks to support the lens capsule during phacoemulsification, and I would like to name them as artificial zonules because they keep the lens in place, especially in the vertical orientation, so we can continue phacoemulsification in the usual way. As you can see, we can imply any technique. You can see here, this is quick chop technique, or we can apply the stop and chop technique, divide and conquer, whatever. You can see that I'm doing phacoemulsification very comfortably, and this part of the surgery is very routine, so I had to fast forward this part of the surgery. And this is the last quadrant, so never allow the anterior chamber to collapse after emulsifying the last quadrant and pulling the phaco tip outside the anterior chamber. So before pulling the phaco tip outside the anterior chamber, it's advisable to inject OVDs inside the anterior chamber to reinflate the capsular bag and to minimize the possibility for the vitreous prolapse into the anterior chamber. Injection of more OVDs trying to inflate the capsular bag, you can see because of the redundancy of the lens capsule, the area of the absent zonule is more appreciated now. We can continue for the next step, which is cortical cleanup by irrigation aspiration, and this is another merit of this capsular support system over the capsule tension ring, because the capsule tension ring sometimes make the cortical cleanup more difficult by entrapment of the cortical fibers in the lens fornix, but the capsular hook system makes the cortical cleanup very routine, quite similar to a routine phacoemulsification case. So this is the best time to implant the capsule tension ring. However, in this case in particular, the capsule tension ring was not available in the OR, so this is a hard situation during cataract surgery, during a routine cataract surgery, and I'm going to show you how we can overcome this hard situation without implantation of the capsular tension ring. So we can overcome this case of mild to moderate lens subluxation without capsule tension ring by implantation of a 3-piece IOL in the sulcus. So in the first step is to implant the IOL, the 3-piece IOL inside the anterior chamber. We had to remove or loosen some of those capsular hooks in order not to interfere with the orientation of the leading and trailing haptic inside the anterior chamber. So the first step is to implant the lens inside the anterior chamber over the iris, and it's time now to remove all the capsular support system. There is no need anymore, and then we can place the lens in the sulcus by flexion of the haptic by the aid of the Sinusky hook to place the haptic from the anterior chamber into the sulcus one at a time. It's not advisable to dye the lens in this case because it might increase the area of the lens subluxation. And now I'm doing the optic capture by pushing back the optic within the lens bag. By keeping the optic of the three-piece lens within the lens bag, we can assume a good centration of the lens, and the optic now is within the capsular bag while the haptics are in the sulcus. And as you can see that the lens is pretty well centered despite the area of mild to moderate of lens subluxation. So, and now we can do some cortical cleanup and injection of acetylcholine to bring the pupil down. You can see the pupil is slightly distorted, and this may be attributable to vitreous prolapse into the anterior chamber. So decision was made to do the pars plana anterior vitrectomy. And of course, we cannot see the vitreous unless we stain it with triamcinolone acetate. And this is another merit for staining of the vitreous with triamcinolone acetate. You can see a big chunk of the nucleus has been prolapsed from the area of the lens subluxation toward the main incision driven by the pressure gradient. So with the pars plana anterior vitrectomy, we can push back this vitreous knuckle from the anterior chamber back to the vitreous cutter to be removed without overdoing vitrectomy and softening of the eye. And as you can see before conclusion of the surgery, the pupil is pretty well rounded and regular, and the lens is centered in place. And now I'm closing the conjunctiva after closure of the sclerotomy with the Vicryl 10, with the Vicryl 8O, and one safety suture of 10O nylon suture to the main incision to be removed 1 or 2 days after the procedure. So now let's move to case number 2. This is a case has been referred to me. The patient had performed cataract surgery somewhere else, and the patient is complaining for a few months of hyperemia after the cataract surgery, and the patient was put on Nivanac eye drops ever since 3 times per day, and the patient is complaining of diminution of vision despite cataract surgery and continuous dull aching pain in the same eye. So examination revealed a pseudophakic eye, and probably a single piece IOL has been implanted in the sulcus on top of open posterior capsule. There is a grade 1 iritis, and the IOP was in the normal range. And OCT has been performed. Macular OCT showed cystoid macular edema, and probably this is the chief cause of diminution of vision in this patient. UBM showed that the lens is confirmed in the sulcus, and the haptics of this lens is rubbing against the back surface of the iris, and this is the cause of iritis, and this is another cause, of course, of the cystoid macular edema and diminution of vision. And that's why a decision was made is to remove this lens and implant a 3-piece lens inside the sulcus. This is a single-piece lens, and this lens is designed to be implanted within the capsular bag. So it's contraindicated to implant this lens in the sulcus because it carries the high incidence of UGH syndrome or ACH syndrome, and the patient, as you have seen here, has been complaining of uveitis, glaucoma, and sometimes hyphemia in other patients. So a decision was made to remove this lens, and now we are ready for implantation of a 3-piece lens inside the sulcus. But at this situation, I remembered one of the most viewed videos of the American Academy website in 2017 by Dr. Fathi Moros from Egypt, when he showed that it's possible to open the anterior capsule even after several years of the primary surgery. So I decided why not to give it a try and try to open this leaflets or to dissect the adhesion between the anterior and posterior leaflets and try to implant a single piece lens inside the capsular bag. Although this situation is a little bit more complicated because we have an open posterior capsule, but I was trying and kept in trying for several minutes trying to dissect these adhesions. And I remembered he showed in his video that the areas of maximal fibrosis, or the white area at the edge of the capsulorhexis, probably was the easiest areas to start with doing dissection. So I followed the same tactic, and with the blunt dissector and blunt instrument, I'm trying now to dissect with the aid of dispersive OVD to dissect between the anterior and posterior leaflets of the capsule. And surprisingly, after 6 months of the primary surgery, I could dissect and open the capsular fornices on either side. So now I have capsular pockets ready for implantation of a single piece lens inside these pockets. So as you can see here, I'm doing the same maneuver on the other side. And it's not necessary for complete dissection of the anterior and posterior capsular adhesions, but rather we have to make sure we have enough space in the capsular pockets on either side to accommodate the haptics of a single piece lens. Of course, we should do some anterior vitrectomy to clear any vitreous might have been prolapsed while doing the maneuver. And now implantation of a single piece lens inside the capsular bag on top of the open posterior capsule. And this is a hydrophobic lens, and sometimes this lens may have the kissing haptic phenomena. We can take advantage of this kissing haptic phenomena. We have some time to manipulate the lens inside the capsular fornices to bring both haptics in the capsular pockets on either side before complete unfolding of the lens of the IOL. So you can see here now the lens has been implanted inside the capsular bag. Of course, we should, before conclusion of the surgery, we should make sure we don't have any vitreous have been prolapsed, and this can be done by the injection of the triamcinolone acetate and doing some anterior vitrectomy. And before conclusion of the surgery, I removed some of those fibrous adhesions at the edge of the capsulorhexis to provide a fresh edge of the lens capsule to get faster adhesion to the hydrophobic acrylate material of the IOL. As you can see that the lens has been implanted inside the capsular bag thanks to a dissection between the anterior and posterior capsular leaflets. The lens has been pretty well centered ever since. I have been following this patient for 2 years so far, and the refraction was very close to emmetropia, and the macular edema has been resolved with the preservation of the foveal contour. So the lessons learned from this case is never to implant a single piece lens in case of open posterior capsule in the sulcus. We have to implant a 3-piece lens in the sulcus. Otherwise, we should do our best to implant the single piece lens inside the capsular bag. The final case, or the case number 3, is another routine case of a 49 years female lady with a soft cataract, and she has been implanted with a trifocal lens in the other eye, and now she was coming for implantation of the same lens in the other eye. The anterior and posterior segment examination were irrelevant, and the case was pretty much routine case, the soft cataract, hydrodissection, hydrodelineation. I usually prefer to do hydrodelineation in cases of soft cataract, and as you can see, I'm applying the same maneuvers and the same technique, which is quick chop technique for nuclear 1 cataract to minimize the ultrasound energy. The rhexis was of average size of 1.5, pretty well centered, and now this is almost the last piece. We have a thick epinucleus. We can deal with either with the phaco tip, or we can just do irrigation aspiration at this stage to clear the this thick epinucleus. I found that it's better at this part of the surgery is to stop phacoemulsification and continue irrigation aspiration, as you can see here. And because I found that it's safer at this time because I found abnormal behavior of the lens capsule, and oops, I could notice a break inside the posterior capsule. So the situation now, we have a very high demanding lady coming for trifocal IOL implantation. She already had trifocal IOL implantation in one eye, and now we have rupture on the posterior lens capsule. So what to do in this case is we have now to continue phacoemulsification. Of course, we should stop, never allow the anterior chamber to collapse, injection of dispersive OVD inside the capsular bag and inside the anterior chamber to trying to minimize the possibility of vitreous prolapse. And now we can continue phacoemulsification. Let's try to clear this epinucleus, or as long as we don't have vitreous, we can continue. But I found that most probably I had vitreous at this stage of the surgery, so we should now stop doing phacoemulsification and we should convert to anterior vitrectomy to clear this epinuclear mass. So with the manipulating the vitrectomy settings, we can use the slow cutting rate and high aspiration, high vacuum to clear these epinuclear fragments together with any parts of the vitreous have been prolapsed from the posterior toward the anterior segments of the eye. And then after, if there is more vitreous have been already prolapsed, we can shift to pars plana anterior vitrectomy with high cutting rate to clear the vitreous that have been prolapsed from the posterior segment toward the anterior chamber of the eye. We can switch again toward the anterior vitrectomy to complete removal of the epinuclear mass inside the anterior chamber, and again we can switch to anterior vitrectomy, either pars plana or a limbal approach, until we have a clear anterior segments of the eye, clear of vitreous and clear of epinuclear shell. And of course, we should stain with triamcinolone acetate to make sure that we don't have too much vitreous. If there is vitreous, we can see, as you can see here, there's a vitreous knuckle prolapsed into the anterior chamber, driven by pressure gradients toward the main incision. And this is, again, one of the merit of the pars plana vitrectomy, that we can clear this vitreous prolapse and push it backwards toward the vitrectomy cutter and clear this vitreous prolapse without doing over vitrectomy. And of course, we should be very careful not to injure or damage the posterior capsule. And as you can see, because now we have anterior segments clear of vitreous and clear of lens matter, you can see that the lens capsule, the posterior lens capsule, become more redundant, and the break seems to be much smaller than I thought. So I had a very good capsular support from the posterior capsule, although I had a break, but after injection of dispersive OVD inside the capsular bag, you can see that the break is limited to the far periphery, and I had a good capsular support to continue implantation of the trifocal single piece lens. As you know that these premium lenses are now available only in a single piece format, not in the multi-piece format. So in this case, luckily enough, because of the good management of the complication during phacoemulsification and doing the pars plana vitrectomy, we could clear all the epinucleus and the vitreous from the anterior chamber of the eye without damaging of the anterior of the posterior lens capsule and without increasing the break on the posterior capsule. So you can see that the lens has been implanted inside the capsular bag, and the trifocal lens now is very well centered, as if a routine cataract surgery, and the patient enjoyed very good vision for distance and beer without any complication. If you have some cortical fibers, we can remove it with a dry aspiration in order not to disturb the anterior segments with the turbulence of the irrigation aspiration. Thank you very much.